Good afternoon, everyone, and thank you for being here and thank you for having me. So today we're going to be discussing pediatric sudden cardiac death. I have no disclosures to share. The objectives of today's talk is that we're going to review the epidemiology of pediatric sudden cardiac death, discuss sports pre-participation physical, and review the cardiac disorders predisposing to pediatric sudden cardiac death. So starting with the first objective, the incidence of sudden cardiac arrest in the young is difficult to ascertain, and that's for so many reasons, mainly because there is no mandatory reporting system for juvenile sudden death, and most data for pediatric sudden cardiac death are allocated post-mortem, such that many cases of sudden cardiac arrest and aborted sudden cardiac death are often not reported. The estimated incidence is about 0.5 to 20 per 100,000 person years. So there is about 2,000 patients younger than the age of 25 that will die from sudden cardiac event each year in the United States. And the incidence is higher in athletes compared to non-athletes with a relative risk of 2 to 1. The prevalence of sudden unexpected death in general and sudden cardiac death in particular is age dependent. So we'll see a higher incidence of sudden death in infancy, mainly because of sudden infant death syndrome. And then the risk falls in early childhood, but rise again in adolescence. This figure to show the age distribution of sudden cardiac death in the Danish population. In this study, they had 114 cases of sudden cardiac death in children aged 1 to 18 years of age in Denmark. And as you see in this figure, that the cases of sudden cardiac death in the first year of life was high and then declined throughout childhood, but rises again from age 13 till the end of teenage years. Although sudden cardiac death is uncommon, it is dramatic presentation and cascading effects in the community and the family make it a newsworthy event. And there is a high degree of concern in the public, and you probably have heard quite a lot of concerns from families that you have taken care of about sudden cardiac death in comparison with other prevalent deadly risk factors of childhood, such as accidents, injury, suicide, and violence. In this figure, it's showing the causes of death in American children, ages 1 to 14, depending on the cause of their death. As you see, heart disease is way less common compared to other causes of death in children, including unintentional injury, congenital anomalies, homicide, and cancer. When we're reviewing the epidemiology of pediatric sudden cardiac death, there is a quite good article, Sudden Cardiac Death in Young Competitive Athletes, that looked to estimate the absolute number of sudden cardiac death in US competitive athletes. They assembled a large registry over a 27-year period. And they had a total of 1,866 athletes who died suddenly or survived a cardiac arrest from 1980 to 2006, who participated in 38 diverse sports. Sudden cardiac death was predominantly due to, sudden death was predominantly due to cardiovascular disease in about 50% of the cases, but also included blunt trauma, commotio cordis, and heat stroke. The most common cardiovascular causes were hypertrophic cardiomyopathy in 36% of the cases, followed by congenital coronary artery anomalies in about 17%. So again, this flow chart showing a summary of what we discussed. So out of 1,866 athletes who suffered sudden cardiac death, cardiac causes for their death were seen in about 50% of the cases. And among these, hypertrophic cardiomyopathy was the most common, followed by coronary artery abnormalities. So let's look at the characteristics of these young competitive athletes who died. So let's start with the age and gender. These athletes ranged in age from 8 to 39 years at the time of death or cardiac arrest, with a mean age of 18 plus minus 5 years. about 65% of them were 17 years old, and about 29% were 18 to 25 years old. And so about more than closer to 95% were 25 years of age and younger. And this is just to highlight the risk in this age group. About 90% of these athletes were males and about 10% were females. And the proportion of cardiovascular death reported in female in this study has increased over time, reaching 12% from the year 2000 to 2006. What about race effect? So white and non-white athletes did not differ significantly with respect to age or gender. However, death due to cardiovascular causes were more common in non-white compared to white athletes. And the fraction of reported death due to hypertrophic cardiomyopathy, and due to coronary artery anomalies were way more common in non-white compared to white athletes, while sudden cardiac death related to ion channelopathies were more common in white compared to non-white athletes. What about the sports and the level of participation? Is there a relationship? In this study, they found that athletes have participated in a wide variety of sports. The most commonly played sports were basketball, followed by football. And most athletes who died because of cardiovascular-related causes were engaged in competitive, again, high school, middle school, or youth sports. So again, the majority of these cases, about 70% of them have died during high school or middle school sports. 7% of these athletes were considered elite by virtue of achieving professional status or national level of excellence. So what about the circumstances of their death? Sudden cardiac death occurred most commonly during or just after physical exertion in about 80% of these athletes. So it's definitely more commonly encountered during exercise, while 20% of them have died suddenly in circumstances not associated with exertion, maybe during routine daily activities or while asleep. In about 16 athletes, they died while submerged in water. So we finished the epidemiology of pediatric sudden cardiac death, moving to discuss the sports pre-participation evaluation. I'm going to start the pre-participation evaluation by going over a couple of cases. The first one is for an 11-year-old boy who came for sports clearance to play high school basketball. He has a family history of hypertrophic cardiomyopathy in his father. His father has not had a genetic testing done. So what would you do next? You decided for this patient to start by getting an electrocardiogram, which appeared normal. There is no voltage criteria for left ventricular hypertrophy, and there is no repolarization abnormalities. You also wanted to get an echocardiogram, and this picture is a still image for a parasternal long axis view at the level of the left ventricle. So in this image, we see the left atrium, mitral valve, left ventricle, aortic valve, and we're mainly going to focus on the left ventricular wall thickness, which appears normal in this exam. So what would you do next for this patient? Will you clear him for exercise or no? We're going to find the answer in the next few slides. The second case is for a 10-year-old boy who presented for clearance before youth league soccer. When asked about a history of syncope or unresponsive spells, his mother mentioned that he had a recent syncopal episode. She mentioned that he was running to the school bus with his sibling, but she noted he started to lag behind. He fell to his knees, screamed, and then fell on his face. He was noted to be unconscious for a period of about 15 seconds and did not require any resuscitative measures. He was noted to have significant abrasions on his face, and when he recovered, he apologized, stating that his legs stopped working. His mother recounts that 2 months ago, she received a call from the school nurse stating that he fell while running during a gym class. The event was also associated with facial abrasions, and his mother attributed his inability to catch himself during his fall because of what she described as general clumsiness and a history of mild gross motor delay. So what would you do for this patient? Would you obtain any additional testing? What do you feel about the history of that the family has described or the mom has described? Again, we'll get to know the answer in the next few slides. So when reviewing the pre-participation evaluation, I think it's really important to reference the policy statement by the American Academy of Pediatric for sudden death in the young, information for the primary care provider, which is a great resource for pre-participation evaluation. I also came across two really good articles that goes about the sports pre-participation evaluation by Miller et al. And the other one is a recent article published this year about a pre-participation cardiac evaluation from the pediatric perspective as well. So all of these are great resources. So when we're gonna look at the pre-participation evaluation, we should ask ourselves a few questions. The first question we'll ask is, what is the purpose of pre-participation evaluation? So why do we do it? We do it to try to identify individuals who may be at risk for adverse health effects, such as illness or injury secondary to sports participation. We also try to diagnose cardiac diseases that predisposes to sudden cardiac arrest and sudden cardiac death. This table reviewed the differences and the challenges that we face in pediatric pre-participation evaluation compared to adults. So as we know, most children or teenagers, they might have vague or unclear symptoms. And as we all know, how teenagers are really extremely poor historian, it does takes quite a lot of efforts and asking the same questions 3-4 times till you get a good answer. While things are much easier in adults, they are able to communicate their symptoms and provide better history. In pediatrics, they're likely going to require repeat screening, as we know. While in adults, they might have already expressed the phenotype of a specific cardiac disease. In pediatric world, parents are too young to demonstrate a phenotype, while in adults, they have older parents with more details about family history. And we also see that pediatricians and general providers who see children are less experienced in interpreting pediatric EKGs, which is quite a challenging task compared to adult EKGs, where we have more clear criteria for diagnosis. In addition to, in children, you see cases of Kawasaki disease, and you're more commonly to see congenital cardiac abnormalities compared to adults. I think it's really important whenever we're doing the pre-participation evaluation to stress to families and patients that a normal cardiac screen means that there is no evidence of cardiac disease at that specific point of time. Meaning it does not mean that my heart is normal forever. It does not mean that I can do whatever I want for till the end of my adolescence. It just means at that point of time, we did not identify a disease or risk for sudden cardiac death, and he is clear to participate. It's really important to stress out to families that new cardiac symptoms or concerns should be re-evaluated. And this has been highlighted by a study where they looked at the risk of sudden cardiac death in about 11,000 adolescent soccer players. And they found that the risk of sudden cardiac death was still about 7 per 100,000, despite extensive cardiac evaluations. So obtained great history, exam, EKGs, and even echocardiogram pre-participation. And the reason for this relatively high number of sudden cardiac death in this study was related to cardiomyopathies that was not picked at the time of the initial evaluation. The mean age of the screening was 16 years, and the time between the screening and the episode of sudden cardiac death was about 7 years. And this is really to highlight the importance of doing the frequency of the pre-participation evaluation more frequent than that many years. So the second question that comes to mind is, who should be evaluated and when should it start? The American Academy of Pediatrics policy statement on this topic recommend that screening patients every 2 to 3 years without differentiation, whether this teenager or child is adolescent, is it athletic or not athletic. It also suggests that screening should be performed starting at age 6. Athletes should be encouraged to complete their PPE at least 6 weeks before participation. The beginning of the summer or near the end of the previous school year is an ideal time. A comprehensive pre-participation evaluation with complete personal history, family history, thorough physical exam should again be performed at least every 2 years, with an annual review of the patient history and a problem-focused examination as needed. And it's also important for providers is that we need to ask questions about physical activity and cardiac symptoms with exertion and family history, regardless whether the patient has a pre-participation evaluation form that we need to fill or no. And that's because, yes, majority of sports are played through the school system. However, there are many sports and athletics activities that can be played outside of the school system, such as like mountain biking, skiing, climbing, which can be pretty strenuous. So it's really important to ask these questions regardless whether you have a form to fill or no. The third question that comes to mind is, where do pre-participation evaluation occur? Does it happen at the primary care physician office, urgent cares, emergency rooms? And the ideal place for this evaluation is for it to happen at the primary care physician office. And why is that? Because so many reasons. The primary care physician know these patients better. They know their past medical history, their family history, their social history. If anything abnormal during the evaluation, they can send the appropriate referrals to the specialist. What about mass screening events? They are time efficient and allow for improved access to medical providers, but there are negative aspects of these mass screening events is that it is difficult to maintain patient privacy. It provides suboptimal environment for physical exam, lack of access to patients' medical records, and difficulty sending the appropriate referrals at the time needed. And the fourth and last question when we're looking at the pre-participation evaluation is, what are the components of this evaluation? So typically, PPEs are based on the pre-participation evaluation monogram that has been developed and endorsed by the American Academy of Pediatrics, American Academy of Family Physician, and the American College of Sports Medicine and American Medical Society of Sport Medicine for the last 40 years. We also have the 14 points questionnaire that has developed by the AHA that we also are going to review. And the PPE in general has 3 and possibly 4 components, including the history, family history, physical exam, and possibly EKGs. And we're going to discuss that shortly. So starting with the history, it is really important to obtain the patient past medical history, ask specific questions about the presence of cardiac symptoms with exercise, and ask questions about odd or suspicious symptoms such as seizure or syncope that can raise suspicion for malignant arrhythmia. And also ask about any known or previously diagnosed cardiac pathology, and that include congenital heart disease, cardiac arrhythmia, channelopathies, cardiomyopathies, Kawasaki disease, where it should be evaluated by a cardiologist before clearance. The history, as we all know, is quite a challenging part of the pre-participation evaluation, and studies have shown that complete agreement between the athlete and their parents' report of medical history on the PPE is less than 20%, and that reflects how challenging history can be. So we need to ask questions to the athletic themselves, the teenagers, as well as their parents to try to obtain appropriate history. Now, the AAP policy statement recommends 4 questions that are directed towards sudden cardiac arrest and sudden cardiac death detection. And these are the 4 questions listed. The first question, have you ever fainted or passed out or had unexplained seizure suddenly during exercise or in response to sudden cardiac noises? The second question, have you ever had exercise-related chest pain or shortness of breath? The third question, has anyone in your immediate family members died of a heart problems less than 50 years of age? And the fourth question is to ask about any family history of hypertrophic cardiomyopathy, Marfan syndrome, long QT syndrome, and other of these arrhythmogenic disorders. The AHA 14 points also pretty much covers the same questions covered by the, or suggested or recommended by the AAP. They add a few more questions to it: any previous history of a heart murmur, elevated blood pressure, any previous restrictions from participation in sports, or any previous testing for the heart ordered by a physician. In regard to the family history, the AHA also recommend asking the same questions pretty much covered by the AAP questionnaire. So we finished the history looking at the physical exam. We're looking at the patient's vital signs, their height, weight, and BMI. Looking at their blood pressure is important. We have been seeing nowadays quite a lot of teenagers coming with high blood pressure. Yes, some of it could be white coat hypertension, but some of them could be true undiagnosed systemic hypertension. It is also to keep in mind that correctation of the aorta in these children or teenagers can be secondary to correctation, or elevated blood pressure in these children and teenagers can be secondary to correctation of the aorta. So it's important to evaluate their femoral pulses, to check their blood pressure in their arms and legs to look for any significant gradient. When we're inspecting these patients coming for their pre-participation evaluation, we should try to identify features that can be suspicious for certain syndrome. So inspect head to toe. For example, if you had a teenager that's tall stature, increased arm span to height ratio, pictus excavatum, scoliosis, should raise suspicion for Marfan syndrome. As we know, these patients are at risk for aortic dilation, aortic aneurysms, and dissections, as well as mitral valve prolapse. Short patients with neck whipping and low hairline and low set ears can be suspicious for Turner syndrome. And as we know, the most common cardiac problems is bicuspid aortic valve and correctation of the aorta, as well as aortic aneurysms as well. Now, pre-participation evaluation will include all organs head to toe, but just for the sake of my presentation today, I'm gonna focus mainly on the cardiovascular exam. We should focus on identifying pathological heart murmurs, abnormal or extra heart sounds, or rhythm irregularity. We know that benign murmurs are common in children. However, sometimes can be difficult to differentiate between benign murmur and pathological heart murmur, which we're sending the patient to a specialist, an appropriate thing to do in these cases. Again, going over the AHA 14 element cardiovascular screening, again, the AHA pretty much recommend the same questions reviewed by the AAP, detection for a heart murmur, evaluating their femoral pulses in case if there is systemic hypertension, looking for signs of Marfan, and evaluating their blood pressure. So now, is EKG required for these pre-participation evaluation? And there is in fact continued debate whether an ECG is recommended routinely for these evaluations or not. The European Society for Cardiology recommends ECG for competitive athletes, and some countries mandate ECGs at various ages. However, the most recent guidelines from the American College of Cardiology, AHA, and American Society of Sport Medicine suggest that EKG may be performed, but did not recommend universal EKG screening. The advocates for doing EKGs will say it's a less expensive test. It can be helpful to detect certain cardiac pathologies, or at least screen for certain cardiac pathologies. However, the people on the other hand, they say, well, if you're gonna do EKGs for all these teenagers and children coming for pre-participation evaluation is extremely costly process. And besides, these EKGs gonna catch lots of false findings and results in additional testing that will be extremely costly for these families. So back to the cases that we described. So the first one, the 11 years old who had a family history of hypertrophic cardiomyopathy but had initially normal EKG and normal echocardiogram. So you decided to clear that patient at that time for sports. However, you did recommend this patient to come back later. In this example, they recommended the patient to come back in 4 years. And at that time, when you listened to the patient's heart, you appreciated a loud heart murmur. So you did an EKG, And now you're started to notice that their EKG appears abnormal. You have more prominent left ventricular voltages in the left precordial leads. You look at the T waves and you see T waves are inverted in the left precordial leads. They're also inverted in the anterior and inferior leads, which suggests LVH with a strain pattern. You decided to obtain an echocardiogram, and now their echoes showed significant left ventricular hypertrophy consistent with hypertrophic cardiomyopathy. This case is to highlight the importance of bringing these patients, even if they cleared him at the first time as recommended by the AAP, they need to get repeat cardiac evaluation at least in another 2 years with annual review of their history and their family history as well. So now in regard to the second case, which was the 10-year-old patient who was having syncopal episode during exercise or while running. For this patient, you decided to do an EKG, and their EKG did show significant QT prolongation at 597 millisecond. You did obtain some labs to rule out secondary cause for QT prolongation, but his labs were normal. There is no family history of long QT syndrome or other dysrhythmia. Again, this is just a picture for the EKG showing that significant QT prolongation for this patient. So now moving to the third objective of today's presentation, which is to review the cardiac disorders predisposing to pediatric sudden cardiac death. When I was trying to prepare for this presentation, it's a quite lengthy topic that, in fact, we're going to dig into all of these causes. It's going to take hours, if not days. So I tried to focus my presentation on the two most common causes of sudden cardiac death, which include hypertrophic cardiomyopathy, which is the most common cause, followed by coronary artery abnormalities. So starting with the most common cause of pediatric sudden cardiac death, which is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy can be defined as a disease state characterized by unexplained left ventricular hypertrophy without other secondary causes or secondary cardiac disease or systemic disease that will explain that degree of hypertrophy. And this is a gross specimen for a heart with left ventricular hypertrophy and hypertrophic cardiomyopathy, and you see the significant ventricular septum thickness as well as the lateral wall thickness in this patient. Hypertrophic cardiomyopathy is a global disease reported in more than 50 countries across all continents, all ethical and racial groups, and in both genders. Its prevalence is about 0.2%, so one in 500 individuals will have this disease. And the prevalence of hypertrophic cardiomyopathy in the general population substantially exceeds that of several other diseases, as you see in this example. This is the prevalence of hypertrophic cardiomyopathy compared to other diseases like cystic fibrosis, multiple sclerosis, and muscular dystrophy. Transmission, as we know, is autosomal dominant, so there's 50% chance of inheritance. De novo and sporadic mutation might arise, and phenotypic heterogeneity is present within and between families. And most patients will demonstrate LVH by early adulthood, and there is accelerated risk during adolescent growth spurt. This table shows the different genes responsible for hypertrophic cardiomyopathy. As we see in this table, the two first genes, the MYPPC3 and the MYH7, are responsible for more than 50% of the cases of hypertrophic cardiomyopathy. So what about the phenotype and morphologic features? The main factor we see with this disease is significant left ventricular hypertrophy that does not necessarily follow a single pattern. Diffuse disease is most common, but a third of the patients have localized hypertrophy, including the apical form, and it can be asymmetric at the level of the ventricular septum. So these are two gross specimens. The first one is for a normal heart showing normal thickness of the left ventricle. And the second one is for a patient with hypertrophic cardiomyopathy. And we see the concentric left ventricular hypertrophy that is more common at the level of the ventricular septum. What about the cellular components? The left ventricular LV myocardial architecture is disorganized in these patients, and they have hypertrophied cardiac muscle cells with bizarre shapes, and the intercellular components is in chaotic alignment as well. And this is at the level of the cells. You see the normal cardiac cells as well as the cardiac muscle in a patient with hypertrophic cardiomyopathy, and you see the difference in pathology. So what is the pathophysiology of this disease? So these patients will get left ventricular outflow tract obstruction, and that is secondary to the systolic anterior motion of the mitral valve. They also have diastolic dysfunction, which is a major component in this disease because their ventricle is thickened, it becomes stiff. They have increased end diastolic pressures, leading to increased left atrial pressures and pulmonary venous congestion. Also, these patients are at risk for a myocardial ischemia because of increased demand secondary to the hypertrophied muscle and decreased supply because of their abnormal coronary arteries. And they also can get mitral regurgitation. And this happens also because of the drag effect of the left ventricular outflow tract obstruction. So how do these patients present? They might present with a heart murmur because of a family history or abnormal EKG or arrhythmia. They can be asymptomatic and they can have severe obstructive form of the disease, and mortality rate is about 1% per year. Sudden cardiac death is obviously the most devastating and unpredictable consequences of this disease. It is the most common cause of sudden death in young adults, as we mentioned, and the mechanism of sudden cardiac death is primary VTAC and VFib. How do you diagnose this condition? We mentioned that an EKG is a very helpful tool. We also rely on an echocardiogram that is very helpful to establish and confirm the diagnosis. And these are still images. The first one on your left is for a normal heart, showing normal heart thickness. And the one on your right is for a patient with hypertrophic cardiomyopathy, showing the significant left ventricular hypertrophy, especially at the ventricular septum. This is another short axis view of the left ventricle, and this is for a normal heart. This is the ventricular septum, left ventricular cavity, two papillary muscles, and this is the RV cavity. And this is for a patient on your right is for a patient with hypertrophic cardiomyopathy, showing the significant increased thickness in the ventricular septum. So the second cause of pediatric sudden cardiac death is related to coronary artery anomalies. And before we go over the anomalies or abnormalities in coronary artery, I thought of including this gross specimen to show you what is normal. So this is anterior, posterior, and this is left, and this is right. So you see the left coronary artery arises from the left coronary sinus, and that divides into the circumflex posteriorly and the left anterior descending, and the right coronary artery arises from the right coronary sinus. So this is the normal origin and course of the right and left coronary arteries. Now there are different types of coronary artery abnormalities that I'm not going to confuse you with this slide. It can be abnormalities of origin, abnormalities of course, or anomalies of termination. When you have abnormal origin, these arteries could arise from the pulmonary artery, or they could arise from the aortic inappropriate sinus. When you have anomalies of the course, it could be because of coronary aneurysms, and anomalies of termination could be because of coronary stenosis or coronary arteriovenous fistulas. So we're going to focus our discussion today on the anomalous aortic origin of a coronary artery, or AOCA. And when we evaluating AOCAs, we ask ourselves a few questions. The first one is, which coronary artery has the anomalous origin? The estimated prevalence of anomalous aortic origin of the left coronary artery with interarterial course is 0.03%, while the prevalence of the anomalous aortic origin of the right coronary artery from the left sinus with interarterial course is 0.23%. And this is just to show you that anomalous right from the left sinus is much more frequently seen than anomalous left from the right sinus. And the cumulative risk of death with IOCAs participating in competitive sports more higher when you have anomalous lift arising from the right sinus. The risk of death percent compared to 0.2% when you have anomalous right arising from the left sinus. And in these cases, there have been case reports of sudden cardiac death with IOCAs at rest or even with recreational activities. So second question that comes to mind is, what is this course of this anomalous coronary? So in this cartooning view, in A, you see normal origin of the left and right coronary arteries. In B, you see the anomalous origin of the right from the left sinus with retroaortic course. In the figure C, you will see anomalous origin of the right coronary artery from the left sinus with what we describe as interarterial, which means it runs between the two arteries, the pulmonary artery and the aorta, with intramural, meaning it runs within the walls of the aorta. And in D, you see a single coronary artery origin. What symptoms do patients with IOCAs have? Most patients are asymptomatic, and in fact, these diagnoses can be established just because you did the echo for something else, and it was an incidental finding, yet you discover anomalous origin. But also these patients can have exertional chest pain or shortness of breath, and that's why for any patients with exertional symptoms, we need to do detailed cardiac evaluation. They can have exertional syncope, and they can present with sudden cardiac death as well. The possible mechanisms of sudden death in these patients is because of compression of the intramural segment, compression of the interarterial segment, acute angle of takeoff, ostial stenosis, and coronary spasms. Again, how we diagnose this condition, an echocardiogram is a quite helpful tool. As we know, it's available, affordable, portable, and non-invasive in nature. The negative aspects of the echo or the limitations of the echo has to do with the patient's body habitus, sonographer experience, as well as poor spatial resolution. Another very helpful imaging modality with a great spatial resolution and frequently used when we're suspecting intramural course for these arteries is a coronary CTA. And these are examples for a 2D and a 3D images for anomalous origin of the left coronary artery from the right sinus with interarterial and intramural course. So as you see in this image, this is the right coronary artery arising normally. However, the left coronary artery, instead of arising from the left sinus over here, it's arising from the right coronary sinus, and the proximal course, it runs within the walls of the aorta, and this is what we describe intramural course. And this is another example for a coronary CTA for a patient with anomalous origin of the right coronary artery with an interarterial course. So again, the right coronary artery, instead of coming from the right sinus over here, you see in this example, it's arising from the left sinus and has an intramural or interarterial course as well. And the final question is, how do we manage these cases? Treatment is in fact in asymptomatic patients with IOCAs with an intramural course are debated, especially when you have IOCAs with an RCA arising from the left sinus of Valsalva. Surgical intervention is recommended in certain cases when you have signs and symptoms of myocardial ischemia, that's an indication for surgery. When you have anomalous origin of the left coronary artery from the right sinus with an interarterial or intramural course, even in the absence of symptoms, because there is a high risk of sudden cardiac death in these individuals. While if you have asymptomatic patients with intramural RCA from the left sinus, in these cases, you have to do additional testing to determine if these patients need surgery or no. And this is just a summary of what we discussed regarding the indications for surgery in these cases. I think this is probably the end of my presentation. I'm happy to take any questions that you may have. Yes, sir.
It seems that if we do a pre-participation exam and everything is normal, including the EKG or ECG, you still don't diagnose HCM. And that's 36% of all the sudden deaths.
So great question.
So it would indicate
Yeah.
that you probably should do something more and echo on everybody.
Well, it's a great question. In fact, one of the studies that I showed, they even did EKGs and echocardiogram for these teenagers before soccer practice, and they did not identify the disease, but later on they have the same incidence of sudden cardiac death. And the rationale or the explanation was for that because they did the time interval between the sudden cardiac death event and the pre-participation evaluation was 7 years. And this is just to highlight again that even if you did the pre-participation evaluation and the patient did not have risk factors or did not identify any conditions or diseases that increase their risk, repeated evaluation is quite important. In regard to your questions about EKGs are quite sensitive when you have hypertrophic cardiomyopathy. So they are, in fact, one of the tables that I might have quickly glanced through is the EKGs are abnormal in about 75 to 95% of patients with hypertrophic cardiomyopathy. So it can be a very helpful tool to detect the disease, to at least screen for the disease and obtain further imaging modalities. Yeah. Yes, sir.
You mentioned earlier when you first began is that the incidence of this is higher in non-Caucasians. The history has stated that the problems that we find in African Americans with a much higher incidence of cardiovascular problems and early death is the result of the fact that many of the African Americans on their trip from Africa to the US, many of them died because of lack of fluids. And those that survived were able to hang on to fluid. However, those that arrived in the United States then carried the conditions that go along with myopathy and cardiovascular disease. My question then is going back to what your original statement was, that there's a higher incidence of this in non-Caucasians. Is this, does African Americans happen to fall into that group with a much higher incidence? And should we then, because of this history that we know in African Americans, that we should be watching these sooner, earlier, and more frequently?
So great question. So I think this is based on the article that I quoted in Circulation, that they reported that the frequency or of sudden cardiac or death related to cardiovascular causes were higher in non-white compared to white population. It's really hard. I don't think they specify exactly what type of cardiovascular causes were identified in these individuals. I think they did comment that it was more frequently seen more in African American compared to Caucasian. However, I don't have specific disease, specific details about what kind of cardiovascular causes of death that was identified in that group. So but back to the study, it was over a 27-year period from, I think, year 1980 to 2006. So I don't think we have a larger scale study since 2006 to look at this question again to see, is it still more frequently seen in non-white compared to white, or is the percentage change or equal? So that's a great question. We don't have an answer, as much as I would love to. Yes.
Hi, thank you. So you mentioned on a sports physical exam, if you found high blood pressure, to check pulses, check arm, leg blood pressures. If all of those seemed okay and normal, what would be the next step you would recommend? Should we keep bringing them back for serial blood pressures?
Yeah, thank you for your question. So obviously the, repeat for diagnosis of systemic hypertension, you need, as we know, repeated 3 elevated blood pressure measurements at least 1 week apart. It's important to think about correctation of the aorta, and that's why obviously you're evaluating for femoral pulses and blood pressure gradient. Also, if the patient has correctation causing their high blood pressure, they should have a decent, loud, harsh sounding heart murmur. So that would be another thing to look at. But obviously repeated blood pressure evaluation is a very reasonable and recommended thing to do. Nowadays we're seeing more and more of systemic hypertension as early teenage years because of different reasons, obesity including one of them. So, yes.
So if you were a pediatrician at a farm worker clinic and you did lots and lots and lots of sports physicals on your kids and they had absolutely no risk factors listed on their form, would you EKG any of them?
No, especially with benign family history, benign personal history, normal cardiac exam, and you did not detect or were suspecting any abnormality. I don't think there's a recommendation to do universal EKGs for these individuals or these patients. In Europe, they do because they have a higher incidence of other causes of death that can be detected on EKG, including arrhythmogenic right ventricular dysplasia, while in the US, it's currently not recommended routinely, unless obviously if there is a question or a reason to do it.
And if you had someone who listed any risk factors, I mean, we get lots and lots of really chubby kids that get out of breath running around the track once or can't run around the track once. And so those kids, I mean, they're coming up as, on the 4 questions, they're coming up as positive for something. Would you EKG all of those kids?
Again, I think the clue is in the detailed history.
Okay.
As much as I would always spend a decent amount of time getting, detailed history from these patients, and history can be quite challenging to obtain. Is it related are they getting short of breath because they're out of shape, or are they deconditioned, or are there shortness of breath happening in max exercise and competitive athletes? So I think detailed history quite important to differentiate. And in these cases, obviously, your level of suspicion, I think it would be reasonable to obtain EKGs and or send the patient to for a consult if needed. Thank you.